just bear with me. I'll share with you some thoughts on strategies to optimize nutrition delivery. So first of all, I think it's worth defining what exactly we mean by that. And I'm not here to tell those of you who are dietitians or nutrition specialists exactly how to or how much you should prescribe your critically ill patients or your critically ill burn patients. But what the literature suggests to me that is at least 80% of that which is prescribed is associated with optimal outcomes. And I'll point to this one data point that comes from very large observational data where we looked at thousands of patients from hundreds of ICUs. And we see this relationship between increasing amount of calories, and I could say the same for protein, and a reduction in the mortality until about 80%, where that line sort of flattens out. And so what it suggests, and which is borne out by randomized controlled trials too, is that getting north of 80, particularly with calories, doesn't seem to have any effect. And certainly if we overfeed, we can cause harm. So at least 80% of that which is prescribed ought to be delivered. And then again, from a very large multinational data set, we observed that not very many patients are actually getting 80%. And herein we looked at what we call nutritionally high-risk patients, and I'm reporting actually the failure rates, the proportion of these high-risk patients that actually failed to get optimal nutrition, or at least 80% of that which was prescribed. And we see very low utilization rates of, say, volume-based feeds or supplemental parenteral nutrition. These are tools that are available to us to try and maximize nutrition delivery. So here we're looking at data from the RE-ENERGIZE trial. You know, we just did a quality analysis and submitted to you your benchmark site reports. And what I'm just showing you here is just an example of one of the slides that illustrates that on average, patients are getting about 70%, maybe a little bit less, of their prescribed nutrition and calories. Those red lines actually demonstrate the site averages, so that there are some sites, or some of you are getting into the 90 or at least north of 80% consistently, whereas others are down in the 50%. But on average, across the study, patients are only receiving about 70% of that which is being prescribed. For the most part, it doesn't look like it's a problem with timing, or starting late. This graphic, and if you just look to the right where we're looking at all sites, you see that on average, sites are starting enteral nutrition on the first day of admission to the burn unit. And even the upper end of the site average is still below 2 days from admission. So maybe the guideline being within 24 to 48 hours of admission, almost 100% of you are achieving that quality metric. So I think it has more to do with just underfeeding. And part of that, or the majority of that, might be to the slow, ramped up approach that people take to enteral nutrition, and the frequent interruptions that occur, mostly due to procedures, but also due to GI dysfunction. And then, when those interruptions occur, obviously we don't compensate for them. And these problems can be overcome by different kinds of feeding approaches. And I'll introduce to you the concept of the Pepra Protocol and volume-based feeds for those of you who are not familiar with it. I will highlight that despite our best efforts, impaired motility or GI dysfunction is one of the major problems or barriers to achieving successful feeding. And I'll go through some strategies that will enable you to prevent and treat that with motility agents. So let's just start by agreeing that when I say a feeding protocol, I'm talking about something that sort of automates nutrition at the bedside. You see on the slide an example of a nurse-driven feeding protocol. I think most of you probably feed something like this, where you start at a low rate. The nurse does an assessment every 4, it could be every 6, or maybe only twice a day, where they're assessed for gastric residual volumes. And if the residual volume is is low, then the rate is escalated up until that target rate of, say, 75, 80 cc's an hour, that which they require to meet their protein energy requirements. Having said that, if the residual volumes are high, then there's something else done in a reactionary mode, either holding or decreasing feeds or adding a motility agent, and then the residual volumes are reassessed until a time where a patient is tolerated. So I could argue based on evidence that every site needs to protocolize their approach to nutrition that will increase the amount of nutrition delivery, rather than sort of just waiting for sort of more of an ad hoc approach where the physician comes by and says, oh, you should start the feeds, or oh, you should advance the feeds. This really should be protocolized. But I could also argue that this slow approach, where you ramp up carefully and slowly, is part of the problem and contributes significantly to that overall caloric and protein deficit, particularly when you consider there is RCT level of evidence that going right to goal, or going right to that target rate of 80 cc's an hour, is acceptable and safe in many critically ill patient populations. So this is a randomized controlled trial of immediate target rate versus that gradual approach like we talked about. And as you can see in this slide, patients who got the immediate approach, basically got more nutrition, more energy, more protein, with no increase or difference in complication rates, serious adverse events, etc. So you can feed more, you can feed better if you just go right to goal, right to the goal rate in this instance. But we actually have changed the paradigm a little bit and prefer talking about volume-based feeds instead of a rate-based approach. And we bundled that together with a few other brainy ideas that we called the Pepra Protocol. So Pepra Protocol acknowledges that not all patients will tolerate the same amount of nutrition, so we have different starting approaches. For someone who's hemodynamically unstable, or for whatever reason is not suitable for high volume intragastric feeds, we can allow you to start with, say, trophic feeds for 24 hours and then reassess. But in all other patients where you're ready to go with nutrition as normal, we don't actually advocate starting at a low rate and advancing slow. And we don't even use the language of an hourly rate. We change the language to a 24-hour volume goal. I'll explain that in the next slide, but let me just also say that as part of the Pepra protocol, we advocate using a semi-elemental solution, and then if tolerated, in the next day or two or three, you can progress to a polymeric solution. I know that 99% of you start with polymeric solutions and then say, oh, they're not tolerating my nutrition, maybe I should switch to a semi-elemental. And I understand that thinking, but if we're trying to maximize the likelihood of success with nutrition, perhaps we should put our best foot forward and start with the solution most likely to be absorbed and assimilated, i.e. a semi-elemental solution. I'm not advocating that I stay on that solution forever during their stay, but just during the initial couple of days when you're starting the nutrition to make sure they're going to tolerate. In addition, we actually advocate the use of prophylactic or preemptive motility agents. I'll again describe in a few slides from now how the peak incidence of enteral feeding intolerance is on day 3. So if you can get them over that hump, day 3, with preemptive motility agents, then discontinue them. And so for that short-term administration of motility agents, we don't see side effects or problems with drug-drug interactions. Similarly, we know that the early phase of feeding is when we observe the most sort of protein debt, and so we advocate preemptive or prophylactic use of protein supplements. When you start the nutrition, start the protein supplements, and then obviously as they tolerate nutrition, if they're getting enough protein, you can tailor, discontinue, or wean down those protein supplements. And then I'll talk more about gastric residual volume thresholds in a few more slides from now, but basically with PEP-UP, we're trying to push the envelope to a higher and higher gastric residual volume threshold. So when I talk about PEP-UP protocol, I'm talking about bundling all of these components together in a feeding protocol perhaps the core basic element is this concept of 24-hour volume-based feeding. And if we were in a live audience, I'd ask you if you'd heard of it before, if you're using it, and if not, why not? Because it really is a superior approach to nutrition. There are scores of both randomized and observational before and after type studies that demonstrate that patients receive more nutrition if you use this approach. And basically how it works is, that patient who, say, goes to the OR for debridement or for whatever other procedure, and their feeds are interrupted, let's say for 5 hours. When the patient comes back to the ICU or to the burn unit, right now, if you're using a rate-based approach, the nurse just sort of reconnects the feeds and feeds along at whatever 80 cc's or whatever that prior rate was, with no compensation for those 5 hours off. Well, with a volume-based feed, the goal changes to a 24-hour target. So this patient requires, say, 1,500 mLs over a 24-hour period to achieve their protein energy requirements. And so if there is a period of interruption, say for 5 hours off, when the patient comes back to the burn unit, the nurse has to do a calculation, but we provide a schedule like this where they have to say, well, they received so much volume before they left to the OR. So that means based on their 24-hour total, they have so much left to give in the day. I have so many hours, left in my shift or in the day, whatever the case may be. So when you look at the amount left to give over the number of hours in a day remaining, you can come up with a new rate. And so basically the hourly rate flexes up and down depending on what volume you have left to give over what remaining number of hours per day. Now, clearly, if we have 2 hours left in the day and we have to give 1,500 mLs, we're not going to give 750 mLs per hour. And so you can see by the sort of shaded in green that we top off that hourly infusion rate at 150, which is a bit empiric. I don't know if they'll tolerate more. Just didn't feel like pushing the envelope. I know I've looked carefully at patients who are getting, higher than 100 mLs per hour, and I do not see any complications or increased risks in that range from 100 to 150. And so that's the concept of volume-based feeding. And I would just point you to the bottom of the screen there, where on our website you can find not only this, but a number of other tools to enable you to implement volume-based feeding or implement the Pepra protocol itself. One of our observations from our work with Pepra protocol is that, if the initial order for nutrition is keep the patient NPO because they're too sick or they're not suitable or you're worried about tolerance, that's that faint blue line on the bottom. And you can see the protein caloric gap that occurs if somebody starts their critical illness NPO. In contrast, if you look at the light green line on the top, that's a volume-based approach. And so quite quickly, you get up to at least 80% of that which is prescribed. And in contrast, if you start on trophic feeds or if you use a rate-based approach, you can see if those middle two lines that you're going to, you may eventually get up to 80%, but it'll be a lot slower. So we really advocate the use of volume-based feeds and Pepra protocols. And like I said, I've tried to make it easy for you. If you're not currently using volume-based feeding, you're not currently using the Pepra protocol, there are a lot of tools on our website that will help you implement, and feel free to reach out to us if you need further coaching. One of the other observations we made as we were implementing Pepra and this concept of volume-based feeds where we try to compensate for time off is that if you have archaic practices where you're holding patients NPO for a possible case the next day at the request of the anesthesiology resident or the orthopedic resident who's doing the case, there are very prolonged periods of time, 12, 14, 16 hours where patients are held NPO for a possible OR case. And you just can't make up for that kind of deficit in a day. And so we've really tried to work with our surgery, anesthesiology, and critical care communities to shrink the time people spend NPO in anticipation of an OR. Particularly, if you've got an intubated patient with a cuffed endotracheal tube and an NG sump drain in their stomach, there's actually no reason why, for many cases, they can't just have their feeds held at the transfer to the OR. If you're concerned about the stomach, suck it out, drain it, end of story. I know that with many of the procedures that you do with your burn patients, you actually feed, through that operative procedure. And so I think those are advanced and needed practices, but I will identify that for some units, they have trouble where, somebody is dictating how nutrition works and they're withholding these critically ill patients for very prolonged periods of time. There's not a lot of evidence in this area, so I'm offering up on this slide sort of an empiric or eminent-based approach to some guidelines to what seems reasonable to a collective group of surgeons and anesthesiologists on how to manage the nutrition in these patients who are intubated and have feeding tubes in. Despite our best efforts and approaches, we will struggle in some patients because of enteral feeding intolerance, which clinically manifests itself as high gastric residual volume. And people use a variety of ranges of what they mean by that gastric residual volume. But for the purposes of this analysis, we let each site determine its own threshold for what they call high. That ranged anywhere from 50 to 500, but on average it was 200 at the time in 2012 and 13 when we collected these data. So about 30% of patients developed enteral feeding intolerance on average around day 3. So it occurs more likely in the early phase of critical illness. And you can see the outcomes, both nutritional and clinical, are worse if you develop intolerance. And of course, it remains an open question if I use prophylactic strategies such as motility agents or small bowel feeding, if I can change those outcomes. But at least we know if you develop enteral feeding intolerance, you're going to have trouble getting adequate amounts of nutrition in. We can look at the underlying cause of the enteral feeding intolerance. It's 99% of the time due to delayed gastric emptying. Unfortunately, there are a multitude of factors that contribute to motility or dysmotility in critically ill patients, some of which may be modifiable. So for example, opioid use, to the extent that we can minimize opioid or narcotics in the pain management of these patients, they're less likely to develop enteral feeding intolerance. Making sure their electrolytes, adequate fluid status, not fluid overloaded. These are other factors that may help. It's not just about nutrition. It's not just about forward flow of nutrition. I use this slide to express a concern that if we flood a dysmotile stomach, we can, in a patient who's lying flat on their back with feeding tubes that violate their sphincters, they can freely regurgitate their gastric contents into their oropharynx. And despite the presence of a cuffed endotracheal tube, this phenomena of microaspiration where secretions can drip into the lungs, and if those secretions are contaminated from gastric contents with bacteria, it's the pathophysiology or the pathogenesis of some of the ventilator-associated pneumonia that we see. So it's not just about feeding, it's also about protecting the patient, minimizing their risks, and maximizing the nutrition delivery. So what are some of the ways that we can mitigate those risks and maximize the delivery? Let me just speak briefly about 4 of these strategies as shown on the slide. I think it's very important that nurses and dietitians, nutrition specialists daily monitor the success of their nutrition, which includes a physical exam, a bedside assessment, an assessment of gastric residual volumes, and that they report on their success on rounds. We hear a lot on bedside rounds about GI function, bowel sounds, etc., but rarely do we hear a nurse or a dietitian saying something like, this patient's receiving 80% of that which is prescribed, or this patient's only getting 66%, guys, we need to do something different. So if we report on it, then it's more likely to receive the attention that it requires. We're more likely to have success. So we really stress the importance of daily monitoring, daily adequacy assessment, and daily reporting. If you're having trouble because of GI dysmotility and you're worried about regurgitation, I'm a big fan of small bowel feeding, or getting the feeding tube beyond the pylorus down into the small bowel. In this analysis, what I'm showing you is we added radioisotope to the feeds, and it was a randomized trial of stomach versus small bowel feeding. And I'm analyzing the data in the way where if I took aspirate of the back of the throat and I saw the radioisotope, I call that gastroesophageal regurgitation. Or if I took an aspirate of the endotracheal tube and I saw the radioisotope, I call that aspiration or microaspiration. Yeah, this was not macroaspiration where we could visibly, see feeds in the endotracheal aspirate. This is this construct of microaspiration. And what I like about this analysis is it shows that you really have to bury the sucker in the distal small bowel in order to really protect your patient. There is this phenomena of duodenal-gastric reflux. So if I just get the feeding tube beyond the pylorus and I think I'm successful, I've bypassed the stomach. Well, in fact, there'll still be a high proportion of regurgitation and aspiration in patients with feeding tip in the small bowel. So strongly encourage you, if you're going to use small bowel feeding, that you advance it as far down into the small bowel as you can go. We know from meta-analyses of randomized controlled trials that you'll significantly improve nutrition delivery if you use small bowel feeding, but also significantly reduce the incidence or subsequent incidence of ventilator-associated pneumonia. I know that some of the reasons you don't use small bowel feeding is it's fussy, it's complicated, maybe difficult to achieve small bowel access. I have a couple of slides of a couple of commercial products. I have no conflicts of interest. I'm just trying to say there are solutions in the marketplace, maybe in your country, where you can acquire tubes that self-guide themselves as the motility of the gut, as of the stomach contracts. It picks up those wings or those phalanges on the edge, on the outer lumen of the tube, and it guides the tube down into the small bowel. And as I report, our experience is greater than 95% success with jejunal placement with this particular brand of tube, but also have had very good success with this particular technology that enables you at the bedside under some sort of an electrical guidance to maneuver the tube down into the small bowel. So, if you don't have this technologies available to you, having a colleague who has endoscopy privileges that can come to the bedside and push the tube down in the small bowel, or last but not least, transfer to radiology under fluoro, achieving that small bowel access. You have to do what's right or easy for you, but I'm just trying to push in the patients who have high gastric residual volumes that you consider that as a therapeutic option to achieve success with nutrition. We've been talking about gastric residual volumes quite a bit. I won't take a lot of time to go through quite an extensive literature on this topic, full of opinion and a little bit of evidence. We know that the problem is if you have a low threshold, say 200 mLs, and you use that as the limiter of your nutrition, you're going to have more problems with underfeeding. So that if we raise that gastric residual volume, you'll have less interruptions and more success with enteral feeding. What's controversial is that there has been a randomized controlled trial of checking GRVs versus not checking GRVs, and it didn't seem to show much of a difference on the clinical outcomes. But I would submit to you that the generalizability of that trial is not suspect, but limited. It was principally in medical patients. Patients got a lot of prophylactic motility agents. So yeah, maybe if you work in a medical ICU and you use a lot of prophylactic motility agents, it would be safe to not check a GRV. But when you're setting up a protocolized approach to care, you really want to make sure you're doing something safe that's going to work for all of your patients. And those patients with, say, abdominal surgery, or say patients in shock, patients under resuscitated, those would be ones that are going to have a lot of problems with tolerance. And if you're not checking their residual volumes in those subset of patients, they could vomit and aspirate and cause pneumonia like we've been talking about. And so as a critical care physician, I like information. So I advocate checking GRVs. I just think we could push the threshold to 400 or 500 mLs. But if we find somebody with a high residual volume, even at that 500 mark, we know for sure they have delayed gastric emptying. And so it would cause me to do things differently, such as make sure the head of the bed is elevated, or consider small bowel feeding, or certainly motility agents. So more information is better. I certainly advocate checking a GRV, but why not push the threshold higher? In those settings where we do see gastroenteral feeding intolerance, we do feel there's a role for motility agents. Both individual trials and systematic reviews of motility agents have shown that for sure they improve gastric emptying, and they reduce residual volumes and improve sort of the nutrition approach. In fact, they can also be used to enable post-pyloric feeding tube placement. Of course, the problem with motility agents is that there are side effects, there are drug-drug interactions, and so we're very careful not to recommend sort of long-term administration of these agents, but rather, whether you're using them prophylactically or in treatment, try them a couple of days. If they're not working, then get on to small bowel feeding or some other approach. So let me just sort of wind down here a little bit by saying, okay, well, everything you've talked about so far, those are standard approaches to nutrition. I'm doing them, but unfortunately, my patients still aren't meeting their requirements. What else might we consider? And I'm not going to go through the literature exhaustively, but I do want to make a point that I think it's much more important that we meet protein requirements in critical illness. I think as a burn community, you're a believer in that, as I know from talking to you and from your practices. And so I'm going to stress in these final slides how strategies to maximize protein requirements. If you push me, I would even say that it's much more important that you get 80% of their protein requirements, and I could care less with the caloric intake as long as it's between somewhere around 40 to 80% of what is prescribed. I'm happy, but I'm not happy if patients are getting less than 80% of their protein requirements. And so what can we do about that? Well, in the last years, there have been a proliferation of very high protein containing enteral solutions made by a variety of different companies. I'm just showing you one slide of products made by Nutricia, but I know almost all the major nutritional companies have a very high protein containing enteral solution. And so these will enable you to get from the 1.0 grams per kilogram per day into that 1.5 on average range of dosing of protein. So I strongly endorse the use of those higher protein containing solutions, but for the targeted protein amounts that you might be using in burns, those too will be inadequate. And so empiric use of protein supplements, like I mentioned when I talked about the Pepra Protocol, in this protocol by Grant O'Keefe in trauma patients where they're trying to get to 2 grams per kilogram per day, they accepted that with their standard enteral solution, you'd get about 1.0 grams per kilogram per day. And so they dose 1 gram per kilogram per day of protein supplement in divided doses, say every 6 hours. And so you can see on the bottom graph there that the combined enteral plus enteral protein supplements, you get by day 3, you're getting up into the 2.0 grams per kilogram per day range of protein. So strongly endorse this concept of starting with your enteral nutrition, but also starting with dosing at 1 gram per kilogram per day in divided doses of an enteral protein supplement. Something that's not very common in burn units, but I think you need to be aware the literature on parenteral nutrition is evolving. And so the risk of infection and the risk of poor outcomes is significantly changed from 20 years ago as we have newer products and we manage central lines differently. So what I'm trying to illustrate here is the combination of enteral parenteral versus enteral alone. And when we look at meta-analysis data, although there's no effect on mortality, there is a significant reduction in length of stay with this sort of combined approach where you sort of dial up the enteral, but you acknowledge that there's going to be intolerance issues or interruptions. So you're covering the patient or you're topping up the patient with parenteral nutrition until you fully establish success with the enteral route. So again, I stress there's no harm signal from modern day PN products and from modern day RCTs comparing enteral to parenteral or enteral to enteral and parenteral. And so for your long-stay burn patients who are at high risk of nutritional depletion, who you're having trouble with the enteral approach, strongly endorse this combined solution. As I said earlier, calories are probably less important. It's probably more important that we achieve protein goals. And so sort of an innovative or novel approach to meeting those protein requirements would be just to consider topping them up with amino acids. Now, I'm not saying you give them IV amino acids alone. This is in the background of somebody getting, adequate or semi-adequate enteral nutrition. They're getting some source of calories, maybe 40 to 60%, 80, maybe even 80% of their caloric requirements, but they're not meeting their protein amino acid requirements. So you top them up with IV amino acids without calories, without carbohydrates or lipids. And that was exactly what was studied in the NephroProtect trial. These are ICU patients at risk of kidney injury. The hypothesis was that the IV amino acids would actually preserve kidney function, improve renal blood flow, et cetera. What it illustrates is that, sure, you can get up to 2 grams per kilogram per day with the amino acids, and it didn't really have that much effect on kidney function and no real difference in clinical outcomes. So you can conclude that, oh, that didn't really work. Why are you advocating it, Highland? Well, at least I would submit to you it confirms the safety of this approach. And in nutritionally high-risk patients, like some of your severe burn patients, there may be a greater therapeutic benefit. But at least we know that this approach is safe for the average patient. So let me summarize by using this figure to illustrate what I think is optimal nutrition practice. And then I'll pause for questions, and feel free to either use the chat room if you don't have a microphone, or to just verbalize your questions. And then I'll have a question or two for you, and then we'll wrap up. So what I've been trying to say here is that optimally, sites should employ a feeding protocol. I would advocate for a second generation or newer Pepra Protocol, or some protocol that implements volume-based feeding in all patients within 24 to 48 hours of admission. I think the most important nutritional assessment should be made around day 3. And you could argue it could be day 4, could maybe argue it could be day 2, but sometime after the feeds have started, you ask the question, hey, am I getting at least 80% in? And if the answer to that is no, there has to be some consideration of nutritional risk. If you've got a low-risk patient, a not so severely burned or a not so sick ICU patient, maybe it's not important that you get 80% in. But if it's a nutritionally high-risk patients, which I think most of the re-energized patients would qualify for with their severe burns, then you've got to fuss if they're not getting 80% of their requirements, particularly 80% of their protein requirements. It would require initially that you maximize the enteral strategies. So, am I using protein supplements? Am I using motility agents? And if not, should I be attempting a small bowel feeding? I'm not advocating, a week of motility agents. I'm advocating you try it for 1 to 2, 3 days at the outset. If that's not working, then you go to small bowel feeding. If those strategies aren't working, I'm not advocating you wait the whole week to figure that out, but rather quite quickly, 1 to 2 to 3 days of trying these enteral approaches. If not working, then you jump right to supplemental parenteral nutrition. We don't want to see our nutritionally high-risk patients languish for weeks on end with an inadequate attention to their nutritional requirements. So let me pause with that's the end of the formal presentation. I have a question if there's a plan to quantify nutrition intake via the oral route. I imagine that's in the context of the RE-ENERGIZE trial itself. Certainly clinically, we would encourage you to quantify nutritional intake via the oral route to ensure, as your patients are transitioning from tube feeds to oral feeds, or if they're never being tube fed, but they're just on oral feeds, you have that challenge of quantifying that. We tried that in the RE-ENERGIZE trial, and we had a lot of quality issues, measurement, and it was time consuming. And so as a collective decision, we decided to abandon that. So no, when we talk about nutritional adequacy in the RE-ENERGIZE trial, we're only talking about inpatient tube fed. And once they transition to starting oral nutrition, we actually stop counting their nutritional adequacy. So it's not like patients are being discounted. Oh, well, I was feeding them orally. No, we don't look at the adequacy once they start on oral nutrition. So all the data I've been showing you and RE-ENERGIZE patients are in those patients during and while they're being tube fed. So no, it wouldn't be bringing your averages down because we don't count those days once they are on tube fed. If you have small bowel feeding, do you go up to a rate of 150 mLs per hour? So great question. I don't have evidence say any differently. That is the threshold we use, and it's empiric. I know that if we deliver large volumes into the small bowel, because the small bowel is smaller than the stomach, that there may be more problems with tolerance and distension and impacting on perfusion. And so,
one second.
In hemodynamically stable challenge patients, I would not recommend going north of 150.
Oh.
I will acknowledge that the Aspen guidelines can say that you don't have to check GRVs, but I tried to explain my position that the one trial that looked at that was in a very narrow patient population with empiric use of motility agents. So there's no data from burn patients as to the safety of this approach, and I would err on the side of caution by continuing to check GRVs, but using a 500 ml threshold. So the question about using 150 as the threshold for small bowel feeding, yes, that's the threshold we use, and I certainly wouldn't feel comfortable going higher than 150 in the small bowel. There's a question about what about MD pushback? I suggested increasing GRV and the MD wouldn't hear it. Yeah, there's a lot of sort of opinion and controversy in this topic. We have published some papers to try and summarize the literature. I can send you, to the extent that physicians listen to arguments and data, I can send you a paper that would enable you to try and have an evidence-based conversation with them. Yeah, Anna, if you only go up to 120 on your volume-based feeds and small bowel feed, that's fine too. I still think 95% of patients will do fine with just going up to 120. There's no evidence to say 120 is right, 150 is right. So some of your surgeons don't believe that small bowel feeding will increase tolerance. I showed you the graph of the meta-analysis of small bowel feeding. It's freely available on our website under the systematic reviews. So again, they can be convinced by evidence. I'll refer you to that meta-analysis plot. Of course, these slides will be available and you can pull it off there too. Some of the comments make me think that some of the challenges you face with nutrition are convincing physicians. I'll refer you to, actually, if I come out of presentation mode, I just want to show you something on our website. Okay. So I just want to point out that some of the resources we have for working with physicians are called nibbles. I don't know if you saw under the resource page down to nibble. A nibble is a nutrition information bite. And these are very concise, usually 1 or 2 pages, nutritional questions where we try and summarize it so that you can take this and share it with your physician as a way of trying to have an evidence-based conversation with them about these different topics. There's small bowel feeding there. I think I might have had a GRV right here. There's the GRV one, but I have a more recent paper on GRVs too that you can use. So I just draw those to your attention to help you communicate these key points with physicians. Well, and I don't want to keep you. I'm very grateful that you paid attention. You put some time into listening to me talk about optimizing nutrition. It's a really important co-intervention in the RE-ENERGIZE trial. So as we get going again, I would really invite you to work as a multidisciplinary team to improve nutrition delivery in these RE-ENERGIZE patients, and then why not in all of your burn patients.